Friday briefing. It's been nearly 2 weeks since the government announced their roadmap out of lockdown. Cases are in steady decline and more people have received their first dose of the vaccine with every day that passes, with over 20 million people now having received their first dose. But we're not safe yet. Yesterday, Public Health England added another variant to the watch list. That's the 8th variant under investigation. And as Independent Sage has repeatedly warned, coming out of lockdown too quickly, allowing transmission to rise, will mean that it's more likely we'll see the virus evolving, throwing out new mutations, new variants. So despite the success of the vaccination programme, we just can't afford to be complacent. We've got a lot to get through as always, so I'm going to stop talking now and hand over to Dr. Kit Yates for a roundup of the latest figures. Kit, over to you.
Great, thank you, Alice. Hopefully you can all see that. Yes. Okay, so latest numbers for today. We've got a lot to cover, so here's what I'm going to be talking about. Firstly, cases and positivity rates are going to continuing to decline across all regions of the UK, but inequality is becoming even more stark the longer this lockdown goes on for. Deaths are continuing to fall rapidly, which is reflecting the falls in cases that we've been seeing since the start of January, since we went into lockdown. And rates of the first doses of the vaccine are slowing down slightly, and second doses are beginning to be ramped up now. So here are the 5 things I'm planning to cover: cases, inequality, hospitalizations, deaths, and then finish with vaccination data. So first up is cases. So this plot is probably very familiar to people. This is the number of new UK confirmed cases per day. So this is people who've had a positive test by reported date. So green is the daily figures, and the overlaid black curve is the 7-day average to smooth things out. And you can see that ever since around the first week of January, cases have been declining, and they were declining quite rapidly. They're now declining slightly more slowly, but that's what you would expect. If this is genuinely exponential decline, then you would expect to see the cases start to fall more slowly as there are fewer of them. So this is sort of expected behavior. Drilling down into the cases per 100,000 per week for the 4 nations in the UK. Red is England, blue is Scotland, green is Wales, and black is Northern Ireland. Again, you can see steep falls from early January in all 4 nations, reflecting the restrictions that have been undertaken since then. And they're all slightly slowing down in their decline at the moment, but we have seen huge falls over the last couple of months. Of course, we've been undergoing quite severe restrictions, so we shouldn't forget that. There's no reason to believe that when you release restrictions that these falls will continue after that. We're always a little bit cautious about interpreting the raw case data, so we're worried that testing might change. So we often also calculate the positivity rate, that is dividing the number of cases by the number of tests that are being undertaken, so that we can control for falls or rises in tests. And these are calculated just based on PCR tests across the home nations, whereas the actual case rates were including lateral flow tests, which hadn't been confirmed by PCR tests for England. So these are just PCR tests. The reason for that is because with lateral flow tests, we know they're often being used for asymptomatic testing, mass testing, and that can lower the positivity rate. If you're testing a whole load of people that don't even think they've got symptoms, then you're less likely to find positives per test. So we just restrict to PCR tests for this. And again, it's the same sort of picture. You can see that the rates are falling across all nations, slowing slightly more recently. And the really good news, I guess, is that England and Scotland in particular have fallen below this 5% threshold. So big falls, and it's good to see those continuing. This is all a bit of confirmatory data. This is from the REACT study that was released on Thursday this week. It tested 165,000 people over a month-long period and came back with 689 positive tests. So not huge numbers, so we should be a little bit cautious about how we interpret this. But they're showing that cases are falling. They've fallen by about 2/3 since the last time the REACT study reported a month ago. And it seems to be showing a slight slowdown, but I'm going to be be warn caution in how we interpret this REACT study, because the numbers of positive tests are quite low. But again, it's a broadly consistent picture, although this is data on prevalence, so how many people are positive at any one time, rather than incidence, which is what I've been showing you so far, which is the number per day, the rate of people testing positive. So a subtle difference, but they should be showing roughly the same thing, and indeed they are. So drilling down to the regional level in England, this is cases per 100,000 per week by region. And you can see again the same sort of trends with really sharp falls. What's quite interesting is that places like London and the south and the southeast had, they started much higher and have actually fallen much further, whereas places in the north, northwest and the Midlands, the East Midlands in particular, didn't start off quite as high, but haven't fallen as far. So actually now we've seen a switch again away from the highest levels being in the south, back towards being in the north again. So these curves all correspond to the north and the Midlands here, the brown and the grey of the Midlands. And that's again reflected in the positivity data. So again, dividing the positive tests by the number of cases. Again, you can see these regions here all correspond to the northern regions, and these ones to the southern regions. So again, we're seeing a switch in where COVID is most prevalent during the lockdown, which may have something to do with relative levels of deprivation. I'll drill down into that a little bit more in a second. So this is just looking at local authority level now. So even drilling down even further than the regional level. So the grey dots are the positivity rates from the previous week. The orange dots are the current positivity rate, and they're ordered from left to right according to the highest positivity rates. And you can see, because most of the orange dots are below the grey dots, we can see that most local authorities have fallen over the last week. The green diamonds at the bottom are indicating where these regions or these local authorities were on the 1st of September. And so you can see that there's actually still quite a long way to go before we get down to the sorts of low levels of positivity in testing that we were seeing back in September. But the good news is that most local authorities are falling and still continuing to fall. The same picture is true in Scotland. You can see that here, most of the local authorities, the orange dots are below the grey ones, indicating a week-on-week fall. Similarly for Wales, there's a couple, 2 or 3 that have risen in Gwynedd and in Wrexham, but mostly they've fallen. And similarly in Northern Ireland, all of the local authorities have seen falls in their positivity rates. So that's good news. Christina talked a little bit about inequality last week, and I just wanted to follow up on that and discuss what's happened over the last week, perhaps. So just to remind you how we're going to talk about measuring this inequality, we're going to be thinking about deprivation as a measure. We're going to break the population down into 5 what are called quintiles. Each one has 20% of the population in there, and they're ranked by deprivation. So the red is the most deprived and the dark green is the least deprived. So by deprivation here, I'm referring to the index of multiple deprivation, which takes into account things like income, employment, education, health, crime, and these areas are ranked by neighborhoods, if you like. So if everything was equal with COVID, if we looked at a particular metric, maybe cases or vaccinations or whatever it is we want to look at, if everything was equal, then we wouldn't expect to see any disparities between these different quintiles. We expect them all to be the same. But as we'll see, this clearly isn't the case. So for example, if I show you, these are just the different regions of the UK, and you can see that there's different amounts of red and green in each of these regions. So they're ranked from top to bottom by highest deprivation. You can see there's most deprivation in the northeast and least in the southeast. So if this was equal across all regions, then you would expect to see the same amount of red, orange, grey, green, and dark green in all of these regions. So looking at the cases per 100,000 per week, now ranked by deprivation, you can see that as lockdown has gone on, the red regions, which are the highest levels of deprivation, are coming to the top. So you can see that they have the highest the highest case levels, whereas the least deprived areas have the lowest case levels. And perhaps this reflects the types of jobs that people are doing in these more deprived quintiles, which means they can't work from home or they're less able to self-isolate. So clearly there are these disparities due to inequality. Again, if I show you the figures for the drops in the cases per 100,000 per week, again ranked by these different quintiles, so 1 being the most deprived and 5 being the least deprived here, you can see there have been drops in each one of these quintiles, but the most deprived areas have the furthest still to go to get back to their September levels. That's these green diamonds here. And even when they get back to these September levels, you can see that there's still inequality there, that the most deprived areas had the highest levels or the highest rates of cases back in September as well. This is what we refer to as a gradient of deprivation, or gradient of inequality. So if deprivation had no impact on COVID's rates, then we'd see each one of these bars being the same height and we wouldn't see a gradient. It would just be completely flat. But as it is, we see quite a steep gradient, with the most deprived areas showing over 100 cases per 100,000 extra per week than the least deprived areas. And this is averaged over the time period from September through to now. So obviously the steeper the gradient is, the worse the inequality is. So I don't know if there was any doubt that there were significant inequalities in COVID rates, then this should put that to rest. And as we slowly come out of lockdown, we risk COVID becoming a disease of poverty if we don't do more to address the structural inequalities that currently exist and that have been further exposed by and exacerbated by COVID. In particular, we bang on about this all the time, but support for people on low incomes to take time off work to self-isolate when required would make a significant difference to address some of the inequalities that COVID exacerbates. So that's enough about inequalities for now, but hopefully that's highlighted that there are some, and that we need to be thinking about that really carefully as we're going forward, so that COVID doesn't become a disease of poverty in the future. Some more positive news: hospitalizations. This is the number of new hospital admissions per day in England. And the black curve is the average, the 7-day rolling average here. So again, you can see really, really good steep falls in hospital admissions, which are obviously reflecting the steep falls that we've seen in cases. So that's clearly removing some of the pressure on the NHS, which is really good news. And the same picture holds at a regional level. If you break this down into the different regions of England, you can see that there's been good falls in all of these regions, which hopefully is taking some of the pressure off. The overall hospital admissions and occupancy levels mask, though, a slightly different picture. So this again is hospital occupancy now rather than admissions, and again you can see good falls there in hospital numbers across England. But this masks what's going on in adult critical care beds. So I'm going to just have a quick look at what's happening in critical care occupancy. So this is broken down by region here, and it's the same plot. So grey was where we were last week and orange is where we are this week. So all regions have seen falls in critical care occupancy, and this has been the case for a few weeks, but that decrease has started to slow in the last week or so. And if you look at in terms of the absolute numbers of critical care beds that are occupied, if you look at where we were this time last year, in all regions except perhaps for the Southwest, we're significantly higher levels of critical care bed occupancy than we were. So the last year's figures are the green diamonds, and this year's current figures are the orange circles. So you can see that there's still a long way to go before we get down to what you could consider normal levels of critical care occupancy for care bed occupancy for this time of year. So it's important to emphasize that all regions are still seeing falls, but that if you look at the percentage of beds occupied, you often hear people saying, well, you know, the percentage of beds occupied is less than 100%, so, you know, there's no problem. But the reason it's less than 100% is because we've had to dramatically increase critical care capacity because of COVID. So the orange curves here are last winter's capacity levels, and the dashed line is the occupancy. So you could see that occupancy always stayed below capacity. But this year, the blue curve is this year's capacity, which we've had to dramatically increase, particularly over December and January. And then you can also see that occupancy has stayed below capacity, but only because capacity has been increased. And actually, if you're looking at, this is England as a whole, you can see that occupancy, this blue dashed curve here, is still above last year's critical care capacity. So if we hadn't done something to increase critical care capacity, we obviously would have been overwhelmed. And I think that people are seeing that there are falls in critical care occupancy, but that has to be put relative to the levels that we would be seeing in previous years, and that's actually way down here, but that we're still above critical care capacity from last year. And that the situation is particularly stark in London, where although we've seen big falls in cases, critical care beds are still, there's a high percentage of them occupied, still over 80% of them occupied, and there's still a long way to go before critical care occupancy comes down below last year's critical care capacity. So there's still extreme pressure on critical care beds in hospitals, which is why we need to make sure that we see cases continue to fall and hospitalizations continue to fall. So that's critical care. And then I'll talk briefly about deaths. So this is our sort of gold standard. This is the number of UK deaths from COVID per week, broken down by blue being England and Wales, purple being Scotland, and yellow being Northern Ireland. This is data registered from death certificates where COVID-19 was mentioned on the death certificate, regardless of the location. And about 90% of these are directly due to COVID. So again, these data are lagged because it takes time to collate the data from death certificates. The latest reporting week is up to the 19th of February, and you can see that we're again seeing big falls in the number of deaths, which are reflecting the falls that we saw in cases earlier and that we saw in hospitalizations. Now, these falls in deaths, although we're still at quite a high level compared to over the summer and earlier in the autumn, these death figures will continue to fall for the next 3 weeks, irrespective of what happens to cases, because they are lagged probably even 4 or maybe even 5 weeks with these particular data, because the data are so lagged compared to cases. So even if infections do start to rise, we'll still see falls in these death numbers for a few weeks. So it's worth remembering that just because the death numbers are still going down, it doesn't mean that the situation isn't getting more serious if we start to see rises in cases. So that's death data. And then the last thing I want to touch on is, again, relatively good news is vaccinations. So this is the number of first doses that are being given out by day. This is in blue, and then second doses in orange. And what you can see is that there are significantly more second doses that are now being given, probably corresponding to people that are coming up towards the 12 weeks from being given their first dose. So I think 12 weeks ago from today was the 11th of December. So we'd literally just started the vaccination program then. So it's good to see that we're getting ahead of the 12-week deadline for a lot of these people getting their second doses. That's really good news. You can see that vaccination has slowed down a little bit in the last week. These numbers are not as high as they have been perhaps in previous weeks, but it's not a huge slowdown, and that may be associated with the challenges in delivering the second dose at the same time as delivering the first dose. It's also possible there might be supply issues hindering the rollout, but we don't have good data on that at the moment. This is the total number of first doses given, broken down by nation. So again, red is England, blue is Scotland, green is Wales, and black is Northern Ireland. And as Alice mentioned, we've given the first dose to over 20 million individuals, and we have approaching 21 million. So that's a really huge achievement. And if we're thinking about the percentage of the total population of the UK, we're approaching a third of the population having been given their first jab, which is really good news. The second doses are obviously much lower, but you can also start to see those ramping up in orange at the bottom there. And then just breaking it down by nation, you can see that actually all nations are keeping pace with each other roughly. England's the highest with 31.6% so far. and Northern Ireland the lowest, but it's still nearly at 30%. So yeah, all nations are doing really well at delivering this, and you can see it's a relatively steady pace for the first dose coverage. The only other thing I wanted to say about vaccinations was when you break it down by deprivation, you see another deprivation gradient, or an inequality gradient. This time it runs the other way, from the least deprived being the lowest, sorry, the most deprived being the lowest, to the least deprived being the highest. And I think that as time goes on, we need to make sure that we are trying our best to address this inequality, to try to make sure that people in the most deprived quintiles are receiving as many vaccinations as people in the higher quintiles. And so there's lots more work that can be done around the vaccine program to help improve uptake. So these percentage figures that I've put on here are percentage of the adult population, and this is just for England, I think, this deprivation data, but you can see that there's a clear inequality gradient there. Okay, so I'll finish by summarising, saying that cases continue to fall, but that has slowed somewhat, but that's somewhat to be expected. Hospital admissions continue to decrease, but ICU occupancy is still high, so we still need to get hospital numbers and ICU numbers down as much as possible. Deaths continue to fall steeply and will continue to fall for the next few weeks, irrespective of what happens when schools go back on Monday. But inequality continues to make its presence felt across the UK and across the pandemic, across lots of different indicators. Vaccine delivery, we've seen, has slowed down slightly, and it's becoming increasingly clear that there is inequality with regards to vaccine coverage, so we should do everything we can to try to address that. What we don't know yet, and what we're looking to see and we'll be following very closely in the next few weeks, is what the impact of schools returning on Monday is going to be into largely unmitigated classrooms. We haven't done very much to reduce the potential for transmission in schools, and so I think people are expecting that we will see cases start to rise, and certainly that's what some modelling papers have suggested. So we'll be following that as closely as we can in the data. So that's where I'll finish, and I'll pass back to Alice. Thanks very much.
Thank you very much, Kit. So some really reassuring figures there, and some really good news as regards the vaccination, and then just this concern about sending everyone back to unmitigated classrooms next week. So we're going to open to questions now, and the first question comes from our special guest, Debbie Abrahams, MP for Oldham East and Saddleworth. Debbie, what's your question?
Good afternoon, everyone. My question relates to the budget this week, and in particular, you all have noticed that the funding in relation to COVID measures has drops off dramatically at the end of this year, and I wondered what your views were on that. Informal discussions with directors of public health have suggested that we will need at least 2 years of follow-up around test, trace, isolate and support to happen, and you know, given the variants that we are seeing emerging, do you think the assumptions are correct?
Thank you, Debbie, for that question, and it looks like Anthony Costello, Professor Anthony Costello, is going to answer that first. Anthony. Oh, I think you're muted, Anthony.
You're not muted, but we can't hear you.
We can't hear you, unfortunately. Would anybody else like to jump in? So Dr. Zubaida Hack, and let's try and get Anthony's mic sorted. Zubaida, over to you.
I would have much preferred to follow Anthony. Hopefully he'll get his microphone back. It's a really important question, Debbie. We were watching the budget, hoping, first of all, that the Chancellor would be putting much more funding forward for self-isolation. We know self-isolation has been a huge problem, the gaping gap, the glaring gap in this government strategy, if you can call it that. And I don't think there was anything at all put forward for self-isolation, let alone any further funding to help people isolate in hotels or anything else. So that was rather dismaying. I think on top of that, we were very dismayed by the fact that the government set up a towns fund to benefit towns, but the areas where COVID cases are the highest, like Leicester, Barnsley, Peterborough, Bradford, Hull, Luton, Manchester, Sheffield, Nottingham, Manchester, and so on. In all of those areas, we know the cases are extremely high. Kit has said to us as well that they're extremely high, as well as Oldham. And yet the government have not included those in any kind of fund, let alone the towns fund. You know, we've had sort of relatively wealthy areas like Richmondshire, the Chancellor's own constituency benefiting, but areas like Barnsley not benefiting as much. And that's really dismaying. So I think we are concerned that government haven't looked at funding in terms of how they can bring cases down and keep them down in deprived areas.
Thank you, Zubaida. Professor Gabriel Scally, and then we might come back to you, Anthony, if your microphone's on. So, Gabriel.
Thank you. Good question, Debbie. And I think there's so many facets to this issue. And what it really needs is a properly expressed needs assessment of what the needs for health in general is, including what is needed for the health service. And that includes remuneration for the staff as well, I should add today. But there is an enormous amount of unmet need in the health service anyway, even under normal circumstances. And that will have been added to greatly by the disruption of the NHS over the past year. So there will be a huge backlog. And that's going to be really difficult to do because of staffing and equipment and hospital bed shortages. So it does require substantial funding for the NHS to be able to catch up on all the things it should have done for people over the last year. I think also public health as well. If we've learnt one thing coming out of this, it is that our public health structures have been impoverished and really substantially degraded over the past decade. And we need to start addressing that for the long term, but also the short term, because it is absolutely clear that as the numbers of virus cases go down, we will still have local flare-ups, so we will still have outbreaks. And there is an absolute requirement to be able to mobilize public health teams at a local area to respond to those. And we simply can't do it with the staff we've got at the moment. So unless there is substantial funding put into that, additional funding put out into the next year, we will have a terrible pattern, I think, of really serious outbreaks going on across the country. So I think there needs to be some decent planning done for this. And we know this government doesn't do planning very well. But this is one occasion when they absolutely need to plan. Their failure to plan for this will damage the health of the population.
Thank you very much, Gabriel. Anthony, would you like to try answering this question? You still seem remarkably silent. So I'm going to go to Professor Martin McKee. I think you had your hand up as well.
Yeah,
Martin.
Thanks, Debbie. And I would actually go even further than Gabriel, because I think that we need to ask ourselves, why is it that, as the OBR report pointed out, this country has been so badly affected? And much of that is because our safety nets were torn. We had so many people living precarious existences. We have people who are just about managing to, as a former Prime Minister said, who are going from day to day, week to week, worrying about their security of income, employment, housing, and even food with the rise of food banks. And that, all of those circumstances have come together to put us in this sort of perfect storm, so that when we were hit by the virus, with all the weaknesses in public health that Gabriel has mentioned, then it just went through the population. And of course, we know that unless we deal with these issues, we are, as Gabriel has said, and Zubaida has said on many occasions, we are still going to have parts of the country that are left behind where the embers will still be smouldering. And as soon as we lift the restrictions, then we will see a resurgence as we did at the end of the first wave. So it would have been nice to have seen some recognition of that in the budget, and also the need for investment to overcome many of these deep-seated structural problems which have been around for a long time.
Thank you very much, Martin. Let's try with Anthony one more time. Anthony, really? We can hear you. Yes.
Fantastic. I thought I'd lost my voice. Just some highlights from the budget, just so that people are aware. 20 million per month for council support for those that can't afford to isolate, so no change. 700 million for catch-up teaching in schools, fair enough. 1,600 million for vaccine procurement next year. And 15,000 million to Baroness Harding's flawed test, trace and isolate scheme to add to the 22,000 million already spent. I mean, that beggars belief. And add to that the fact that destitution in Britain has more than doubled to over 500,000 households who are in destitution. And we don't know the levels of childhood hunger and the stress that that causes in all kinds of ways. And then, of course, the threat of unemployment for so many people. We don't know how high unemployment's going to go later this year and whether they're going to get access to benefits and the rest. So we're in a very, very serious situation. And I cannot for the life of me see why they are defending a privatized test, trace and isolate system that clearly doesn't work, and spending a fortune on it.
Thank you very much, Anthony. Thank you for the question, Debbie. We're moving on now to take some questions from the press and the public. And first up, we've got Nigel Nelson from the Sunday People. Nigel, are you there?
I am indeed, Alice, thank you. Parents have to give permission for schools to test their children. Given the importance of testing, do you think that schools ought to be able to exclude children whose parents don't give that permission?
Thank you very much for that question. Who would like to start with this one? Zubaida.
Nigel, we were just discussing this question. It's it's such an important question, and of course, it's totally unclear. It's totally unclear because literally what the government have done is pass the buck to parents and to head teachers when it comes to mass testing. First of all, you know, it's not just about consent. I mean, I think at the moment, schools themselves don't know what they're going to do, what the response from parents will be in terms of consent. And can they really turn away children where parents don't give consent about these tests? There's also the issue, Nigel, actually, very few tests will be done in school. I think literally the first 2 or 3 will be done in school, and then it will be handed over to parents. And so I think a much bigger question is, you know, to what extent can these tests really be given untrained to parents? You know, to what extent can we really justify the fact that there's no supervision? And what does no training and no supervision mean for the efficacy of these tests? Can we really rely on these tests? So there's lots of questions around tests that haven't really been answered. And as I've mentioned, I think the bigger concern is that the government have passed the buck on this. Lastly, I want to say, just about everything, just about all the new measures in schools, and there aren't very many at all that have been introduced. It's mass testing and face coverings, but only for secondary school students, are all voluntary. Now, that creates a chaotic system, an absolutely chaotic system. So once again, we see that the government and Gavin Williamson have failed schools, have failed children, and have failed parents.
Thank you very much, Zubaida. Professor Susan Mickey.
Thank you very much for the question. I think with training, there are 2 types of training. One is how to actually get the sample from the swab. It is very skilled work, and we know that there are a lot of false negatives. And part of this is because the swab doesn't actually go to the places it needs to go to. And especially when you're doing with children, when the reflex of gagging might be quite high. So I think there's a real question mark about how many false negatives there are going to be. We know there's a lot anyway, even when it's done in a very skilled way, but that is a real problem. The second kind of training that's really important with this test is the communication about it. The way that it's explained that this is for identifying cases. So it really only has any meaning if there's a positive test result. It doesn't have meaning if it's a negative test result, but the chances are high that people will interpret that, or many people will interpret that as giving them some kind of reassurance that they aren't infected. And the important communication is that if you get a negative result, it doesn't mean that you're not infected. You may easily be infected. It's just that this swab hasn't picked it up. So on both those counts, I think this is a very high risk strategy, because if people are falsely reassured, then they may loosen their guard in terms of the protective behaviours and therefore increase transmission.
Thank you very much, Susan. Dr. Kit Yates, you'd like to respond here as well.
Hi, Nigel. Yeah, I think the situation in primary schools is a bit different, where the emphasis is on the parents to go and pick up tests from test centres and then to test their kids and then to report if they get a positive result. And, parents have been homeschooling their kids for the last 8 weeks. And speaking as a parent who's been homeschooling a 5-year-old and a 7-year-old, it's been really hard. So what parents are going to want to voluntarily go and test their kids and risk having to then go and homeschool their kids for a couple more weeks? Who's going to want to do that voluntarily, especially if you're in a low-income family, and that really puts you in a massive bind? It's perhaps okay if you're well off and you can afford to take the time off to homeschool your kids, but who is going to want to voluntarily do these tests? And so I think making it voluntary means that it's going to be a largely ineffective system.
Thank you very much, Kit. I think there was somebody else who wanted to respond here, looking around the panel. Was there anybody else that wanted to respond? Perhaps not. I hope that's answered your question then, Nigel. Thank you very much for joining us today. Next, we're going to take some questions from the public. And first, we have Margaret de Bethlin. Margaret, are you there?
Yeah, I can't
We can
I can't show my video.
Oh.
Thank you for taking my question. In view of the new variants in the UK, how much is our current decline in numbers due to lockdown, in your view, and how much due to the vaccine programme? Is the Brazil variant really not likely to spread much or become dominant, as the press seems to say, or is it merely quiescent due to lockdown?
Thank you very much, Margaret, for that question. So how much of the reduction in cases is due to vaccination? How much of it is actually due to lockdown? Dr. Kit Yates, I think you'd like to respond here. And then I wondered if Professor Cole-Friston might want to come in as well. But Kit, you can start.
Thanks for the question, Margaret. I think the vast majority of the reduction that we're seeing is due to lockdown. We have vaccinated the older end of the population, at least given the first dose, and we are starting to see an effect there, and there is evidence to suggest that these vaccines can reduce transmissibility, but it's probably too early to be seeing that effect to a significant degree, especially because the people who are doing a lot of the mixing and spreading the virus are largely the younger end of the population, and they are the working age people, and they are people who haven't been vaccinated yet. So a lot of the falls that we're seeing, almost all the falls we're seeing, are due to the lockdown. In terms of the variant, we're sort of fortunate at the moment in that we've been importing these new variants at a time when the reproduction number is below 1. So what you would expect to see is that chains of transmission would naturally be broken. We've also been doing the surge testing to try and find these cases, but the situation will change when we start to open things up and the reproduction number becomes above 1, because then you wouldn't expect chains of transmission to break naturally. So we've been fortunate in that these variants have come at a time when cases are falling and that chains of transmission are breaking, but when we go into a situation when R increases, we might not be so fortunate. So we really do need to think very carefully about border control in order to make sure that we aren't importing these new variants, which potentially spread faster, potentially more lethal, and potentially have the ability to evade existing immunity.
Thank you very much, Kit. And Carl, can I come to you for a response to this? Professor Cole-Friston.
Sure. So it's an excellent question, which everybody's asking themselves at the moment. I think one useful way to think about this is just in terms of the mechanics of viral spread. And that depends on three things. It depends upon the contact rates, the transmission risk, and the amount of time that you're infectious. And that, I think, nicely splits into three, the different targets of our responses, and also tells you immediately that all of the factors that you mentioned are very operational, are having a very material effect on the decline in numbers. So, contact rates are reduced by lockdown measures and travel restrictions. But the key thing here is the transmission risk. And that itself can be decomposed into two things. So that's going to be the propensity of the virus to transmit itself. And clearly that's where the variants of concern get into the game, in the sense that some viruses might have a greater propensity to jump from one person to another. But there's another important aspect to that transmission risk, which is the things that we do in terms of mask wearing, social distancing, and also a key factor here is the seasons, in the sense that if we spend more time outside or the daylight is longer, we reduce propensity for aerosol transmission, for example, which can actually have a profound effect on the transmission risk that may, in principle, completely reverse any changes in the transmissibility due to the variants of concern. And so bring that to the table, because it's not just lockdown and it's not just the transmissibility due to variants. There's also a dynamic in play over the next few months, which comes under the rubric of seasonality. That is going to be, I think, quite an important determinant, and speaks to a possibility that we will be in, for the summer months, a much better position, in the sense that the reduction in the transmission risk due to the fact it is summer and we're all outside and the temperature is much higher, will put us in a very comfortable position in relation to reaching the herd immunity threshold. On the other hand, it does ring warning bells in terms of what's going to happen next winter, when those seasonal fluctuations, which can be quite profound, sort of kick in again as winter approaches.
Thank you very much, Carl. I'd like to bring in Professor Stephen Reicher and then Professor Susan Mickey. So, Stephen.
I think one of the real problems here is that often these things are posed in an either-or way, that it's either the variant or it's our behaviour, and if it's one, it's not the other. And the government has been arguing at times that it's because of the variants that we've had problems, and that's the entire explanation. Actually, of course, it's an interaction of the two. But if something is more transmissible, it means to the extent that you are close to others, to the extent that you have contact in others, you're going to have more of a problem. So in other words, it's the two together that are equally important. And the fact there are new variants, and incidentally, remember that the latest variant that's emerged in the last few days, that is apparently they're called variants under investigation, VUI, to determine whether they're variants of concern, VOCs, is homegrown. And it makes the point it's all the more important to have infection suppression measures, that the vaccine on its own will be undermined if we don't have vaccine infection suppression. And that again, making it either this or that, either vaccines or infection suppression, is actually a major problem. So I think the point to be made is, yes, there are variants, some of which are more transmissible, but that doesn't mean that our behavior and contact is less important. It makes it all the more important. And also it makes it all the more important that the government puts in place measures that make environments safe, whether that be in the school, and various people have made that point repeatedly. Zabeda very eloquently stresses that point, whether it's the workplace or whether it's hospitality, that limiting interaction is partly about our behavior, and it's partly about the government taking its responsibilities seriously to keep us safe from all variants, including the new variants.
Thank you very much, Stephen. Susan, over to you.
Thank you. Well, just to add some evidence to this issue, a few weeks ago, the report of the vaccination rollouts in Israel showed that there was an increase in transmission rates for I think it was 9 days after vaccination, which was, I think, unexpected and puzzling. And the authors suggested that the reason for this was that people were letting down their guard in terms of protective behaviours after being vaccinated. And so transmission rates went up until the immunity conferred by the vaccination had done its thing. And that takes up to 3 weeks for that to happen. And then interestingly, Public Health England released their data within the last week, which showed exactly the same thing. And then a large survey, I think ONS, of 2,000 people, yesterday, I think it was, released data, and one of their findings was that those people who've been vaccinated, 41% in the previous week had been in contact in other people's homes with people that weren't carers or their bubble. And so you put all that together and you can see what we've got is a really risky situation for those 3 weeks before people are getting the immunity built up, whereby is likely to be looking forward to the vaccination, kind of false reassurance that A, they're protected, and B, they're not infectious, and therefore having much more social contact, and therefore transmission goes up. So I think the lesson here is incredibly important at this point in time, for those 3 weeks after being vaccinated, that people should keep going with all the protective behaviours, because we absolutely need to get this rate of transmission down much, much lower to prevent the kind of variants emerging that may actually undermine the whole vaccination programme.
Thank you very much, Susan. And that's incredibly important advice, isn't it, to anyone that's been vaccinated? Don't drop your guard. And certainly don't rush out for those 3 weeks after you've been vaccinated thinking that you're protected. You're not. Right. Unless anybody else wants to. Yes, they do. Dr. Tallulah Onu would like to comment on this as well. Tallulah.
Thanks, Alice. A lot has been said. I just want to augment a point that Carl made about the transmission risk as part of that equation, because we talked about the transmissibility of the virus. And so I just want to explicitly say that the other things to bear in mind that influence the transmission risk as well are how quickly we can identify cases and contacts, and how quickly we can isolate cases and contacts from the population. So I just want to explicitly mention that, so that we don't think it's just the characteristics of the virus that impacts that aspect of the equation. And so everything that we do in terms of early testing of cases and contacts and supporting isolation of both cases and contacts will be really critical to that part of the equation.
Thank you very much, Tallulah. Anthony, did I see your hand? I did see your hand.
Actually, my point was very similar to Tallulah. It addresses Carl's third point about the period of infection as well. But the important thing to remember is that these different strategies of lockdown and behaviour and find, test, trace and isolate assume different importance at different stages of the epidemic. So when cases fall, as they are now, and as they come right down, if you can isolate people quickly, get their tests back, isolate them quickly, you can lock down this. That's what Korea, China, Vietnam, Thailand did. They didn't ever have national lockdowns. They did have partial local lockdowns. So it's very important that we don't mess up again and don't rely totally on the vaccine, that we also have this in place. That's why we emphasize it so much.
Thank you very much. Thank you for that question as well. And now we move on to Phoebe Collins in London. Phoebe.
Hi, thank you for taking my question. Can you comment on how immunosuppressive medication will affect vaccine efficacy and duration of efficacy? Should people who are clinically extremely vulnerable be and taking immunosuppressant meds, should they be checking their antibody levels regularly to ensure they are in fact protected? Is there any good data out there?
Thank you very much, Phoebe. Really interesting question. Who would like to take this? We're all wishing that Dean and Pillay was here, but I'm sure there's enough virology expertise amongst the panel. And Professor Martin McKee, over to you.
Well, I'm not a virologist, but we do know that there is a very wide range of immune responses anyway, and factors such as age and obesity, for example, as has recently been shown, will diminish the immune response anyway. So I think what we will see is there is a spectrum of immune responses which will be influenced by a whole series of factors, and not just whether they're immunosuppressed or not. But I think but that is in terms of looking at the antibody titers. I think that we probably are not yet in a position to answer your question, because there are still so many unknowns about the relative role of antibodies and cell-mediated immunity, and the many different ways in which the immune system responds to the virus. So I think it's early to say, but I'm sure that we will be getting much more insight later.
Thank you very much. Does anybody else want to comment on this question?
Just on the point, the commonest cause of immunosuppression in a sense is pregnancy, because when you're pregnant, you naturally suppress down your immune system. And one of the issues that does come up is whether or not you should get a vaccine or not. And that's something you discuss with your obstetrician, I think. But there are certain people, I know of 2 people recently who have been advised to have the vaccine after 14 weeks of pregnancy, because they were in high exposure situations. They worked in special schools, I think. So that is an example of where there is, giving a vaccine preemptively to people who are immunosuppressed. But if people have got more serious immunodeficiencies, that requires careful clinical assessment.
And there is a trial underway among pregnant women anyway at the minute to look at that.
Thank you very much for those responses. Thank you, Phoebe, for your question. And we're moving on now to Nikki Gibbs in Oxfordshire. Nikki, what's your question?
Hi, everyone. A panel of scientists from several countries around the world have recently confirmed that a drug called ivermectin can significantly reduce infection and deaths from COVID. So I would like to know if ivermectin is a viable option for the prophylaxis and treatment of COVID-19.
Thank you very much, Nikki. I can see that Professor Martin McKee is keen to answer this one. Martin.
Simple answer, no. There is some laboratory evidence that ivermectin may have a role against the virus in a laboratory condition, but there is no evidence whatsoever to justify its use at all. But it is being very widely promoted on the internet. We all see it, and we all get people advocating it to us, but no, the evidence is not there.
Hasn't there recently been a trial published where it didn't have any effect?
Yeah, I think there may even have been that, but there is certainly no evidence in its favor whatsoever.
That doesn't rule out a role in prophylaxis, but it's very speculative.
Very
like
speculative.
A lot of these. So I agree with Martin.
The other thing that's being looked at the minute is colchicine, but that's the subject of that's being put into I think the recovery trial. I mean, we need to see, but again, we just need to get evidence. We need to get good evidence from clinical trials rather than speculation based on some finding in a laboratory, because that can lead you seriously astray.
Thank you very much, Martin and Anthony. And it sounds like we have had clinical trials then of ivermectin, and they haven't yielded promising results.
That's what I understand. Wasn't there one published a couple of weeks back? And I'm not sure whether it was a preprint or a peer-reviewed trial. I'll check it out now and let you know.
Thank you very much. Thank you for that question, Nikki. I know that we're all desperate to find a panacea, but one is not forthcoming at the moment. Moving on now to Venetia Kane from Glastonbury and Somerset. Venetia, what's your question?
Hello, thank you. I'm concerned, sorry, my video won't go on because you stopped it. I'm concerned that people seem to be thinking that it's going to be a free-for-all as far as personal contact's concerned from the 21st of June. Just the other day, I had an email from an elderly relative who's also a bit of a maverick saying, yippee, we can throw away our masks in June. So I pointed out that in the small print of the roadmap, there was the fact that there's a review coming up as to matters like social distancing and masks. So my question is, what do you think will be the situation then from a scientific point of view anyway, even if you can't say politically? Thank you.
Thank you very much, Venetia. Who would like to comment on this? A bit of crystal ball gazing. Where are we going to be in June? Professor Gabriel Scally.
Yeah, I don't really do crystal balls very well or with any enthusiasm, and I prefer to play the game as I see it playing out in front of me. But if I was to look that far forward, the first thing that comes to mind, having listened to your question, Venetia, is will we have vaccination for children and young people in place by then? We don't have a vaccine, and they compose such a significant proportion of the population that even if everyone else was vaccinated, that's far, far too many people not to have the disease circulating and not to have serious outbreaks going on in particular communities. And there will always be people who will not be vaccinated. Either they won't develop immunity following vaccination because the vaccination isn't 100%, or they will not have had it because they've got contraindications such as allergies, or they will not have had it because maybe someone persuaded them not to go for vaccination. And that will vary enormously across the country. So there will be places where there will be still a lot of people who will not be immune to the virus, and we will still see outbreaks happening. So I think, yes, it will be a lot better in a lot of ways, but we'll not be out of the woods by then, I'm afraid. And you may have to tell your elderly relative that it's not quite as simple as that. We're on the way, but I don't know if we'll be far enough down the road to be able to throw away our masks completely.
Thank you very much, Gabriel. I think Stephen Reicher wants to come in, and there's a couple more people after that, but Stephen, over to you.
It was interesting that just before this, I was commenting for the BBC on the press conference by Nicola Sturgeon and her spokesperson, Jason Leach. And they were asked questions of this sort. The big concern in Scotland is that given it's the first time for a long, long time that Scotland have got to an international football tournament, will the Euros go ahead? And will we see games of 50,000 people at Hampden Park? Now, their answer, I think, was very good indeed, which is at this stage, we simply do not know and we cannot know. What we do know is that if we were to do it now with an incidence prevalence rate of about 1 in 200, it would mean that there would be 250 people at Hampden Park who would be infected, because Hampden Park has 50,000 people, and that would be a potential catastrophe. So we can't know. The only question we can ask is, how do we make it more likely? Not when, but how. And the danger is that if you give a date as if it's a set date, it's a fatalistic date, then it makes people passive. You just wait for it, and you wait for the doors to open, and then you're told that you can go out and play, with the very real danger that you can't, and that hope turns to despair. If, on the other hand, you say, look, it is dependent upon the vaccination rates and the infection rates. And these are the things we can do to bring those down in partnership. This is what the government will do, and this is what the public will do. And my very real concern is that the mantra of data, not dates, has turned into dates, not data, And that's precisely the mistake we made last year. And the very real possibility is that that will slow things down. It won't speed things up. It won't make you freer sooner. It will slow things down because it stops asking the question, what can we do so that we can go and hug the ones we love and we can go and watch Scotland beat England at Hampden?
Thank you very much, Stephen. Zubaida, over to you.
I think there's two things to consider here. First of all, it's not clear, as Steve has suggested, that about how the government are going to be bringing cases down, because we're coming out of lockdown. So how are they going to continue to bring cases down, keep them down, and importantly, and we've said this many times, including Gabriel, keep them out. We've got a border quarantine policy that's extremely porous. You know, we know that the one person is now untraceable with the Brazil variant. That those are really huge concerns, and all of those things suggest that, you know, at the moment there is no real strategy to keep the virus down. That's the first thing. The second thing is, of course, as we've suggested time and time again, the vaccination program alone at the moment, particularly because it excludes children at the moment, is not enough to rely on. We do need that virus suppression strategy. And we talked about inequality, and I want to bring this point in again, which is that when you look at the demographics of young people, there are more young people among ethnic minority groups than there are among the white population. So something like half of the mixed ethnicity group are under the age of 18. A quarter of Asian groups are under the age of 18. They won't be vaccinated. And we know that those groups are much more at risk of COVID-19 infection and death. So all of that suggests that we really need a strategy to keep cases down. And at the moment, as Steve has suggested, it's not clear what that strategy is because we're purely driven by dates and not data.
Thank you very much for your question, Venetia, and thank you for all those responses. Moving on now to Liz Bennett in Manchester. Liz.
Thank you. I wanted to ask, what do we know about variants of concern and what do we need to know?
Lovely. So variants of concern, what are they? What do we need to know about them? Who would like to start with these concerning variants? Professor Martin McKee.
Well, I can say what we need to know about them. I mean, obviously, people do know a great deal about them. I suppose the biggest question that we don't have a clear answer to is whether we're seeing what we call convergent evolution, and that we do have these mutations, these variants, deletions that are happening in many different places. And are they taking us towards a situation in which you will have a sort of variant of the virus, which is a perfect fit for the receptors, and then any further variants will be less good of a fit and will be less competitive? Or will it be like influenza, where you're constantly changing the genetic material and going in a divergent way? I think the emerging consensus, although it's not a complete consensus, is that the most likely is some form of convergent evolution, which would be good news in a way, although of course, in that it means that you're not going on with a sort of infinite future with constant changes. So I suppose that's the first thing that we need to know, and we don't yet know that. But then obviously what we need to know is, to what extent is the virus more transmissible? To what extent is it more lethal? To what extent is it transmissible for a longer period of time, as some of them seem to be? And then will it, of course, evade the vaccines? And we need to, and that's quite a complicated question, because it's not just about the responsiveness to the antibodies, because there are these other types of immunity that can play a role as well. And also it's possible that different types of vaccine, because there now are so many different ones that just have the spike protein, ones that use converted other live and killed viruses, that may react differently in terms of cross-reactivity. So I think still a lot that we don't know, but clearly we're getting more information all the time. But I think I would be hesitant to speculate too far as to where we are going in the long run.
Thank you very much, Martin. Anthony, you'd like to come in?
Just actually, that was a very comprehensive answer from Martin. I'm not going to add to that, but just to say on the ivermectin, question earlier. There was a paper published in the Lancet eClinical Medicine a month ago, which was a pilot, double-blind, placebo-controlled, randomized controlled trial of ivermectin in non-severe COVID patients. So it was a kind of test. They did not show any significant effects on viral load or symptoms, apart from the fact that the ivermectin treated groups seemed to recover from loss of smell a bit quicker than the others. But it was a small trial, and they actually at the end said it does warrant having much bigger trials. So I imagine that that will get tested in due course. So we can't rule out some kind of beneficial effect, and we don't know what it would have an effect on severe cases.
Thank you very much, Anthony. Does anybody else want to comment on variants of concern at this point? Well, hopefully you feel that your question's been answered, Liz. We're moving on now to our next questioner, who is Ken Hall from Bristol. Ken. Are you there, Ken?
Okay, you can hear me.
We can hear you. Go ahead.
Good. Okay. My question was about the detail we need to. What detail do we know about how these lockdowns work? This is a very blunt instrument at the moment. There was an outbreak recently in a town somewhere in the Midlands, I think, and the mayor was interviewed, and he said that the outbreak had been particularly in supermarkets, but he didn't say whether it was between the customer to customer or customer to the staff, or between the staff. And I wondered whether there's very much been done on drilling down into the detail of how effective lockdowns work. The same goes in schools. I mean, do we know whether it's pupil to pupil, pupil to teacher, parent to parent? That's the kind of thing, really, as to whether we know about the detail, so that we could make maybe the lockdown a bit less of a blunt instrument. That's it.
Thank you very much, Ken, for that question. Gabriel Scally.
Well, it is a good question. Kind of, I could phrase it, answer it rather differently than right on in terms of the lockdown thing, because lockdowns are only one tool we can use to help us deal with a really serious situation, and we've lots of other tools. And one of the reasons why we don't have some of the information you're we're asking for is because we're not doing the other stuff, and we're certainly not doing it properly. For example, if you really want to know where people got infected, you have to do backward tracing. You've got to not just trace their close contacts they may have had since they became infected or developed symptoms, but you've got to trace back, well, where might I have got this virus? And you've got to work backwards and find people. So that's why when Independent Sage is talking about this whole process, we start with find, then test, trace, isolate, support. And again, with the testing that is done, we don't do the testing in the way that it is recommended internationally. We do it in our own very peculiar way, which is when we find people who are at high risk of having contracted the virus because they've been a close contact and spent time in the company of someone who is tested positive, we don't test them. What we do is they are told that they should self-isolate and only come forward for testing if they develop symptoms. Well, we know a lot of people either don't develop symptoms, even though they may develop the virus and become infectious, or sometimes they develop very light symptoms and don't recognize it as being COVID-19. And we miss all of those cases, and we miss the backward tracing for them. So a lot of those questions that you quite rightly ask for, we simply don't know because we don't do the job properly. Some of them we do know from questioning people, well, where have you been? And when you look at the data from where have you been that you might have picked up the virus type questions, well, yes, retail, food retail is one of the most common places that is answered, but that's because it's one of the most common places people go. And you can't really, really tell where people got it unless you do that backward tracing, like finding the roots of the tree of infection, as well as trying to stop it spreading further. So those questions are not answerable easily, and the reason they're not answerable easily in the UK is because we don't do find, test, trace, isolate, and support the way that Independent Sage has been suggesting, and the way that the international guidance has been suggesting. It needs to be done. Thank you.
Thank you very much, Gabriel. And Susan, you'd like to comment?
I think the question you're asking about the transmission and the infection rates in different settings, whether it's shops, whether it's transport, whether it's hospitality, is incredibly important. And as Gabriel says, we know very little about it. And the reason it's so important is if we had more data about how transmission is happening, the amount of it, but also what type, the extent to which it's by droplet or aerosol or by touching surfaces, we'd be in a much better position to be having much more effective measures to prevent transmission. There's some research being done in London Transport actually, where they're looking to see what surfaces have virus and actually looking at measuring aerosol transmission within buses and within tube carriages and how it circulates. So this is really important research because without that, we really, are in a very poor position to make progress on this. But if you look at the investment in research funding over the whole of the last year, and you compare how much went into pharmaceutical interventions, which are incredibly important, obviously, compared to all the behavioural, environmental, social, and systems interventions put together, only 4% went into the latter and 96% went into pharmaceuticals. So this isn't commensurate with what needs to be done in order to develop our measures to much more sophisticatedly break intervention pathways, transmission pathways rather, and therefore resort to these blunt lockdown instruments. So one thing I would really advocate, and I'm advocating in many different forums, is to ensure that the investment is put into the research so we do have more evidence and more data on this important question.
I'd like to come back to you on that, Susan, because how much of that do you think is driven by the fact that nobody's going to make profits out of changing behaviour?
Well, as a scientist, I would hate to speculate on the reasons. As if I were a politician, I might. But I think that is one of the problems, is that the behavioural, environmental, social systems interventions are largely preventative. And I think where you're going with that question is they're not making direct profits, whereby obviously vaccines and drugs are making substantial profits globally and in this country. But if we are to see the bigger picture of the finance and the economies for this country and worldwide, it's obviously an incredibly false economy to put 96% into the pharmaceutical industry and only 4% into all of the rest of it put together.
Thank you very much. Stephen, you wanted to comment here as well, briefly, if you can.
In my spare time, when I'm not at Independent Sage meetings, I've been doing a bit of historical reading, and I've discovered some fascinating myths about past pandemics, fascinating misnomers. So, for instance, apparently the Black Death was never called the Black Death at the time. It was either called the Big Death or the Great Mortality. And as many people know, Spanish flu didn't start in Spain, it started in the United States. And the great misnomer of this pandemic is the term NHS test and trace. And we know it's not NHS test and trace, it's Serco test and trace. And it's because it's Serco test and trace, it's privatized, it's away from localities, it's not based on local public health systems that people trust, that it is unable to do precisely the type of tracing that Gabriel talked about, that backward tracing, which depends upon knowing your patch. So one of the main reasons why we've had problems, and one of the main reasons why we haven't been able to do the fine-grained analysis, which allows us to escape lockdown is precisely because it's Serco test and trace, not NHS test and trace. And I do apologise to Sir David, because I know he always says that, so you'll have to find something else to finish on today.
Thank you very much, Stephen. Tallulah, you want to comment as well, but I do want to squeeze in one extra question, so please be brief. Sorry.
Yeah, no, just speaking of myths, I think the other, just to touch on, is the word lockdown itself as an intervention. So you rightly identified it as blunt. I just want to tease that apart a little to say that it has different components, and we often use that broad stroke word lockdown, but in reality, we rarely talk about the fidelity of implementation of those different components, because that has it has implications for what we mean when we say, does it work or not? If we are trying to interrupt contacts between people and transmission risks, if the lockdown is implemented in a way that doesn't do that, then we can't, it is not effective calling it the same lockdown as a lockdown that actually does that. So it's just really important when we talk about the word lockdown to say, well, it's not just an intervention. It's not a drug that we give. What do we mean by that? We mean interactions between people in outdoors, indoors, at work, in social spaces. How is that being implemented? You know, we know in the second lockdown, there were more people going to work, more interactions in public transport, more school, etc. So it's difficult to compare to say, well, did the second lockdown work better than the first lockdown? It's like, well, that intervention was not implemented in the same way. So it's just really important. I think that detail is really critical when we talk about the blunt intervention.
Thank you very much for those answers. Thank you for the question. And I suppose the summary of that is that we don't know, and we're not looking hard enough. I'm going to squeeze in one last question. It has to be a quick one, I'm afraid. Sophie Sweetman, are you there, Sophie?
Yep, I'm there. Hold on. Oh, stop my video. Okay, my question is, oh, my phone's chosen that moment to go off. In terms of access to, can you hear me?
We can hear you.
In terms of access to healthy information, so everyone gets a chance to look after themselves, how do facts, like the one I saw on the NHS website in February 2020, that we don't get enough sunlight to make vitamin D in the UK in the winter and spring, impact the severity, caseload and distribution of COVID-19?
So sorry, Sophie, so what's your question specifically?
It's basically saying that the information, like Susan mentioned, like preventative measures, that in February 2020, I went to the vitamins and minerals page of the NHS website, and it said that we don't get enough vitamin D in the winter, and that when you've got ethnic minorities having more COVID-19, especially amongst healthcare workers and young people, and inequality, that access to information about healthy living must be very important. And do we know whether vitamin D deficiency is increasing the UK COVID-19?
Thank you very much. So a couple of questions there. One which is really about communication, and the other one is about vitamin D. Susan, you would like to respond?
Just on the vitamin D issue, many years I was on a National Institute of Clinical and Care Excellence panel, which was specifically looking at vitamin D and health in the British population. And back then, it's called NICE as the organisation, did recommend vitamin D supplements, especially where people either don't have fair skin or don't have a lot of access to sunlight. So it was recognised that if people are spending a lot of time indoors and the skin isn't taking in a lot of vitamin D, then supplementing is a good idea. I've also heard subsequently that vitamin D is recommended in terms of preventing susceptibility to COVID, but I've only heard that secondhand. I haven't looked at the data, so I hope Anthony will give chapter and verse on that one.
Thank you very much, Susan. Anthony, would you like to come in?
Well, just to say that, yeah, vitamin D deficiency is a common issue and certain groups are more vulnerable. And a lot of people rightly take vitamin D supplementation, as Susan said. The only trial, I mean, there's been a big lobby for vitamin D throughout this. And, you know, I get lots of emails and stuff about it. In terms of does it prevent you getting, if you take vitamin D supplements, we just don't have that data or the trials as far as I'm aware, unless Martin's seen anything recently. There has been one big trial of treating people with vitamin D in, you know, who are sick with COVID, but it didn't show any impact. That was published recently. Martin, do you have more?
Yeah, no, the latest NICE evidence is that we should be taking it anyway, but the evidence that it actually prevents COVID is not there. But they do recommend further research. There was a so-called trial that was published from Spain, but that was really problematic when people looked into that, because it was presented as a clinical trial, but actually wasn't. And there were all sorts of issues about different numbers and different arms. In fact, it was almost a teaching example of how not to do a trial, and it was alleged to have provided evidence in favor of vitamin D.
Thank you very much, Martin. I'm really sorry. I know there are other people that want to comment, but I'm going to have to wrap things up. Thank you very much for all the questions today, and thank you very much for all of those responses. Before we completely draw things to a close, I'd like to invite Sir David King to sum up as usual. Sir David.
Thank you very much, Alice. I think once again it's been a wonderful meeting. Let me just say, we have an amazingly good success in the vaccination story. 21 million people, very nearly, have had at least one vaccine dose to date, and all delivered through the National Health Service in this very efficient way. But before we get too euphoric about the role of the vaccines out into the future, we just need to recall what Kit Yates said. We have a long way to go still to reach where we were in September 2020. There was the lost opportunity when we had gone into a proper lockdown and we unlocked the lockdown far too early and started celebrating Christmas in October, November, and off went the second wave, which has produced, in the end, far more deaths than the first wave did. So we have really seen a very poor handling of this situation through early undoing of lockdowns, and also, in particular, through the inability to separate people who have the disease and people who've been in touch with them from the rest of the population. We're all worried about the transmissibility of any new variants of the virus that can emerge, and in particular, whether the vaccines will deal with these new variants of the virus. And so that will be continually challenging the thinking going forward. For my money, the most important statement today came from Anthony Costello, who reminded us that the budget left a few major questions announced by the Chancellor, and in particular, the funding of a system that since May last year has failed. And Stephen, I'm afraid I have to refer to it. The Find, Test, Trace, Isolate and Support system, having cost 23 billion to date, into the private sector, has again received the major funding in the Chancellor's statements, another many £billion going into a failed system. What we don't understand is why that cannot be contingent on seeing that it works. And that has never operated in the way that the system should work. And we're just reminded that we're not following the international agreed procedures on running a find, test, trace and isolate system. It's not too late. We still have to do it. But at the same time, I think we're all getting very worried that it's never going to happen. Thank you.
Thank you very much, Sir David, and thank you for all the questions today. Thank you for watching, whether you're watching us live or catching up. Thank you to all the scientists. Every single scientist on Independence Age is a volunteer here. They're doing this because they think it is important to share their expertise, but also to hear from the public. And that new report on the roadmap and the other reports that have been published over the months are all there on the website, along with details with biographies of all of the scientists on the panel. Please do follow Independent Sage on Twitter if you don't already. And we've also launched an Instagram account as well with the handle @IndependentSage. Well, what else? So you can follow us there for more visual information. We'll be back same time, same place next Friday. Stay home if you can. Stay safe. Keep well. Thank you, everyone.
Bye.
Thank you. Bye-bye.